chronic obstructive pulmonary disease actually describes a few different diseases. It's kind of an umbrella term, and it includes chronic bronchitis, chronic asthma, and emphysema. So in someone with chronic obstructive pulmonary disease, there can be any one of those three diseases present, or indeed combinations of those disease processes present. And the chronic bronchitis and emphysema, the main cause by far and away is inhalation of smoke, and this is caused by smoking tobacco, and also smoking cannabis will cause COPD as well. And people in poorer countries are often obliged to live in smoky environments to warm their houses and cook their food, and inhalation of wood smoke will also lead to chronic obstructive pulmonary disease. But I want to look at chronic bronchitis and emphysema separately. So let's start off with chronic bronchitis. Right, what causes chronic bronchitis? Well, itis obviously is inflammation of. Bronchitis is the bronchial tree. So it's anything that causes inflammation of the bronchial tree. And as we've said, that is usually smoke irritating the lining of the bronchial passages, irritating the respiratory lining. But other pollutants can also cause bronchial irritation, and a damp climate seems to make it worse as well, a damp, cold climate, similar to the one we have in England, in fact. So, what's the pathophysiology? What's going wrong here? Well, the smoke is going into the airways, and that's irritating the airways. So what the airways try to do is to protect themselves. And the layer that protects the epithelial cells of the airway is the mucus. So what the airways do as part of their inflammatory response is to produce more mucus. So you get more mucus produced. So smoke is causing an inflammatory response, and there's more mucus produced. And as well as that, to increase the ability of the airways to produce mucus, there's hypertrophy and hyperplasia of the mucus secreting glands. Now, hypertrophy means the individual cells get bigger, and hyperplasia means that more cells grow. And these include the mucus secreting glands in the submucosa, that is underneath the epithelium. Now, the epithelial lining the airways is lined with mucus, so it's called a mucous membrane. And underneath that is the submucosa. And there's mucus glands in the submucosa, and these get bigger. And there's also an increase in the number of goblet cells. The goblet cells are the mucus producing glands. These are the unicellular, they are single cell mucus producing glands in the mucosa. But of course, as these glands get bigger, they can't expand out the way because of the rigid wall, which often contains cartilage in the larger airways, so they expand in the way, and that's going to reduce the lumen of the bronchial passage. There'll be a narrowed bronchial lumen, meaning less air can get in and out. And also the inflammatory process is going to cause edema, and that is also going to narrow the lumen of the respiratory passages as well. And of course, the more mucus that builds up, that's also going to reduce the lumen, because instead of being fresh air in the middle of the passages, there's lots of mucus in the respiratory passages now. So all of these things will reduce the diameter of the bronchial passages. And if you've got one of the black pathophysiology books, there's a diagram of this on page 209, where you can see a normal lumen and a reduced lumen. The reduced lumen is caused by the swelling of the submucosa, the swelling of the mucosa as a result of edema, and the accumulation of mucus within the lumen of the bronchial passage. And as well as that, there's so much mucus, it's hard for the mucociliary clearance system to get rid of it, and it can't get rid of it effectively. So this means that the mucus hangs around for a long period of time, because there's too much of it to cough it up effectively, to get rid of it effectively. The sheer volumes of mucus just overwhelm the cilia. So the mucus is hanging around for a period of time. That means there's a mucus stasis. And this means two things. If there's a mucus stasis, it's more likely to get infected. Because normally a bacteria would stick to the mucus and be wafted out by the mucociliary clearance system quite quickly. But if there's large amounts of mucus and it's not being cleared, that won't happen. And the other thing that happens is the longer the mucus is hanging around, the more it dries out and the more viscous it becomes. And that means that the stasis is made even worse by the viscous, dried out mucus. So you end up with far too much thick, sticky mucus. But at this stage, the disease process is reversible. So if someone's been smoking for a few years and then they stop smoking, the airways can get rid of the excess mucus and can recover. So early disease is reversible. But if someone goes on smoking for a longer period of time, especially in the smaller airways, there's going to be the progressive development of fibrosis, and there's going to be a chronic bronchiolitis. The smaller bronchioles will be affected, as well as the larger bronchi, as well as the larger bronchial passages. And also the normal ciliated columnar epithelium, which comprises the mucosa, that is, comprises the epithelium lining the airways, those columnar ciliated cells will gradually change to become squamous cells. This is an example of metaplasia. And this means two things. One is the cilia are going to be lost, so the mucociliary clearance system will work even less efficiently than it did before. And also, because the squamous cells are a metaplasia, it greatly increases the chances of getting a squamous cell carcinoma, one of the types of bronchogenic carcinoma. So there's this ongoing chronic condition. But we get lots of these patients in hospital. Well, we get lots of them in all the time, but especially when the weather gets worse. Because what happens is they get a bacterial infection on top of the chronic bronchitis. In other words, they get an acute bronchitis caused by bacteria, as well as the chronic bronchitis caused by the inflammation from the smoke. And this makes them really quite poorly. Indeed, it's a life-threatening situation. It's called acute on chronic bronchitis. And of course, that needs treated with antibiotics to try and get rid of the infection. So what about the clinical features in chronic bronchitis? Well, it's clinically defined. Chronic bronchitis actually is defined as a cough for 3 months of the year over 2 consecutive years. So it's defined by the amount of coughing, and the coughing is usually productive with quite large amounts of mucus being expectorated. And it's surprising how much some patients can cough without really realising it, because it gradually increases over the years. They might start with just a bit of coughing in the morning, then they get more coughing in the morning, then they can cough throughout more periods of the day. And some people just think this is normal, but actually it's not. Coughing is abnormal. And especially producing the large amounts of mucus is abnormal. And as time goes on, there's progressive shortness of breath, progressive dyspnea, and the lungs are going to work much less efficiently because the bronchial passages are much smaller than they should be. Much less oxygen is getting through to the alveoli. And as well as that, as well as less oxygen getting through to the alveoli, it becomes harder for the carbon dioxide to get from the alveoli out again. So because there's less oxygen getting through to the alveoli, less oxygen is getting into the blood, and this means that the oxygen saturations can drop. And this can cause cyanosis, the blue discoloration of the skin, caused by an increased amount of reduced hemoglobin in the superficial blood vessels. In other words, cyanosis is an indicator that the oxygen saturations are low. And as well as not being able to get the oxygen in, as we've said, it's harder to get the carbon dioxide out. That means the amount of carbon dioxide in the blood increases, causing a hypercarbia. There's an increase in the amount of carbon dioxide in the blood. Now, because the levels of carbon dioxide in the blood are increased over long periods of time, this can overwhelm the hypercarbic drive in the medulla oblongata. So physiologically, the brainstem will detect an increase in the amount in carbon dioxide and stimulate breathing. So if you take a deep breath and hold your breath, the reason you need to start breathing again is because the amount of carbon dioxide builds up rather than the amount of oxygen reduces. It's hypercarbia that is the primary respiratory drive in a healthy person. But in chronic bronchitis, because they can't breathe the carbon dioxide out, there's a chronic hypercarbia, then this actually overwhelms the carbon dioxide receptors in the brainstem, and increased levels of carbon dioxide will no longer stimulate breathing as effectively, because these people are chronic carbon dioxide retainers. And this means that very often these patients don't hyperventilate to try and compensate, because the primary stimulator of the hyperventilation, the increase in carbon dioxide, is no longer able to stimulate the hypercarbic drive. So these patients are sometimes described as non-fighters. They don't try and hyperventilate to compensate for the hypercarbia and the hypoxia. However, if they do exercise, they become short of breath on exercise. Now, this is explained because when they exercise, they'll start using up the limited amounts of oxygen they have in their blood, and the fall in oxygen will be detected by the carotid bodies between the two carotid arteries, between the internal and the external carotid arteries. And this will stimulate the respiratory centre in the medulla oblongata independently. So when the levels of oxygen drop sufficiently, that will stimulate respiratory effort, causing shortness of breath on exertion. But when they're just sitting there, they don't hyperventilate to try and compensate. But because these patients are chronically hypoxic, that's detected by the kidneys. The kidneys respond by producing erythropoietin. The erythropoietin stimulates the red bone marrow to produce more red blood cells. So very often these patients are polycythemic. They have more red blood cells than would be physiologically desirable in their blood. But the main clinical feature is these patients are coughing a lot and coughing up large amounts of mucus. And of course that's good. It's good to get rid of all the mucus you can. It's just a pity it was produced in the first place. Now occasionally you can get some flecks of blood in the mucus. There is, you can get a degree of hemoptysis. But if there was larger amounts of blood, that would merit investigations. Now another interesting feature is that patients who are developing chronic bronchitis often cough a lot in the mornings, so they'll wake up and start coughing. Now what happens here is through the day when they're smoking, the smoke actually paralyses the cilia. So the cilia are unable to waft up mucus as part of their role in the mucociliary clearance system. They can't waft up the mucus because they're paralysed by the smoke. Smoke paralyses the cilia. So that means all day when the patient's smoking, they are not able to waft up the mucus, and they accumulate lots of mucus in their bronchial passages. And then when they go to bed overnight, hopefully when they're asleep, they're not going to be getting up to smoke. So that means there's a period of a few hours overnight where they're not smoking. This allows the cilia to recover, and the cilia start wafting the mucus up again. That means by the time the patient wakes up in the morning, there's lots of mucus in their trachea, and they then need to cough this up, because that's what coughing is. Coughing is moving mucus from the trachea through the vocal cords up into the oropharynx. And once it's in the oropharynx, the patient can decide to swallow it or spit it out. Now, a complication of chronic bronchitis is pulmonary heart disease, what used to be called cor pulmonale in the old days. Now what happens here is the patient has chronic bronchitis, so the airways are narrowed. That means less oxygen gets into the alveoli, less oxygen gets into particular areas of the lung. And when there's less oxygen in the alveoli, the pulmonary arterial vessels vasoconstrict. So low levels of oxygen in the alveoli cause pulmonary arterial vasoconstriction. Now physiologically this is a good idea because it means if there's not much oxygen in one part of the lung, less blood is sent there to pick up oxygen which is not available to be picked up. And that will leave more blood available for areas of the lung which are well oxygenated. Because if areas of the lung are well oxygenated, that will cause a reflex pulmonary arterial vasodilation, and more blood will be sent there to pick up the oxygen. But the key point to grasp in understanding pulmonary heart disease is that if there's a lack of oxygen in the alveoli, that will cause a vasoconstriction. But of course, in chronic bronchitis, all of the lung, there's a global reduction in the amount of oxygen getting to the alveoli. So that means that all of the pulmonary arteries will vasoconstrict. So you'll get a global pulmonary arterial vasoconstriction in response to the reduced amounts of oxygen in the alveoli. Now, if you vasoconstrict the pulmonary artery, what's that going to do to the pressure? Well, if you vasoconstrict, that's going to increase the pressure. So these patients will develop pulmonary arterial hypertension, high blood pressure in the pulmonary artery. So there's not enough oxygen in the alveoli. The lack of oxygen in the alveoli causes a vasoconstriction. The vasoconstriction increases pulmonary artery pressure. Now, what is it pumps blood into the pulmonary artery? Well, it's the right ventricle that pumps blood into the pulmonary artery. And if it's pumping blood into the pulmonary artery, but the pressure in the pulmonary artery is higher, this means the right ventricle will have to work harder. There's an increased resistance because the pulmonary arterial pressure is higher. Now, if a muscle works harder over a period of time, that will cause hypertrophy. So initially, the pulmonary arterial hypertension will be compensated for by right ventricular hypertrophy. But as time goes on, the right ventricular hypertrophy will lead to right ventricular failure, and the right ventricle will not work properly. This means the right ventricle won't be able to pump out all the blood that is returned to it from the right atrium. And of course the vessels taking blood into the right atrium are the inferior and superior vena cava. It is the large systemic veins. So because the blood can't get through the right ventricle, the blood's going to be dammed back into the right atrium, and that's going to dam blood back into the inferior and superior vena cava, and from there blood will dam back to all of the systemic veins in the body. That's going to increase the blood pressure at the venous end of the capillaries, and that's going to mean that less tissue fluid is going to be able to be reabsorbed back into the capillaries from the tissue spaces. As a result, there's going to be more fluid left in the tissue spaces, and what do we call it when there's too much fluid in the tissue spaces? Well, we call that edema. So in other words, the lung disease causes heart disease, and that causes edema. And that's actually what pulmonary heart disease is. It is what it says. It is heart disease caused by lung disease. So just to run through that again, there's not enough oxygen in the alveoli. That causes a vasoconstriction. That increases pulmonary arterial pressure. That increases right ventricular workload. That causes right ventricular hypertrophy, that causes right ventricular failure, and that causes systemic edema. So these patients become edematous, they become bloated. Now remember, we already said these patients were hypoxic, so they were cyanosed, they had a blue colour, and now we are saying that they are bloated as well. So these patients can be blue and bloated. That's why chronic bronchitis patients are sometimes described as blue and bloated or blue bloaters. So what do we do about this? Well, improve the health of the patient as much as we can. They should take some exercise when they're able to do so, and they should stop smoking. Stopping smoking at any stage is associated with improved lung function and will reduce symptoms and improve quality of life and increase life expectancy. We need to encourage expectoration to try and get rid of this stagnant mucus to reduce the likelihood of infection and to try and get rid of the obstruction from the bronchial passages. If they do have any bacterial infections, we should recognise these early and we should treat them. We can give these patients bronchodilators such as salbutamol nebulizers. If there's an asthmatic component, we can give them inhaled corticosteroids as well. And we want to take their peak flow measurements before treatment and then after treatment so we can monitor the effectiveness of the treatments that we are giving. But we know that giving long-term oxygen therapy at home is beneficial. If the patient has more oxygen, using an oxygen concentrator at home, that's going to increase the amount of oxygen in their alveoli. If you increase the amount of oxygen in their alveoli, what's that going to do to their pulmonary arteries? Well, if there's an increased amount of oxygen in the alveoli, that's going to allow pulmonary arterial vasodilation. If the pulmonary arteries vasodilate, that's going to reduce pulmonary arterial pressure and reduce right ventricular workload, preventing right ventricular failure. So we know that if patients have supplementary oxygen at home over the years, for as many hours a day as possible, this is associated with a significant improvement in prognosis. And also long-term oxygen therapy will reduce polycythemia. But we know from a lot of research data that it does improve survival. Certainly give these patients influenza vaccine. And sometimes when these patients are admitted, they need quite high doses of antibiotics if they have infection, and they might need non-invasive ventilation, probably using continuous positive airway pressure devices such as masks, or these days hoods are quite popular. Now this podcast has dragged on for a bit, so I think I'll do emphysema as a separate podcast. I'll do emphysema as a separate podcast.